Hello friends, welcome to Creative Medicine. In this lecture, we will learn about. Hello friends, let us now learn some important points about parathyroid gland. So in the parathyroid, first we will learn about men syndromes. So in the men syndromes, the first men syndrome is men 1 syndrome, which is also called as Werner's syndrome. Remember what is Werner's syndrome? If it is Werner's syndrome, it is actually helicase defect is Werner's syndrome, which will result in premature aging and progeria. Okay, then in Werner's syndrome or men 1, you will see autosomal dominant. It has triad. One, it is parathyroid tumors are present in this with pituitary tumors, and you will also see presence of pancreatic tumors. So this is 3P: parathyroid, pituitary and pancreatic tumors. So first, the gene responsible for this men1 is actually the men1 gene, which is seen on chromosome 11. And this men1 will code for the protein called as menin. Then, if you see the characteristic features, so first we will see all the features. There will be parathyroid hyperplasia will be there for the patient, and there will be pancreatic endocrine tumors will be there, and you will also have pituitary adenoma. This is the main triad. Along with that, there will be other manifestations are also seen, like less common manifestations, like you will see presence of adenocortical tumors will be seen in the patient with, you will see presence of adenocortical tumors with bronchial and thymic carcinoids will be seen, and also you will see collagenous Collagenomas are seen, and you will also see presence of facial cutaneous angiofibromas. You will see presence of facial cutaneous angiofibromas are seen, and then you will also see presence of subcutaneous visceral lipomas are seen. Subcutaneous visceral lipomas are seen. So what do you see? What are the less common lesions which you see here? You will see presence of adenocortical tumors will be seen, and bronchial and thyroid carcinoids will be seen. Collagenomas, bronchial and thymic carcinoids with collagenomas, and facial cutaneous angiofibromas are seen, along with the subcutaneous or visceral lipomas. First, we will see some important points about parathyroid gland things. If you were asked what is the most common endocrine abnormality associated with men1, is actually it is multiglandular parathyroid tumors is seen in men1 most commonly. Okay, then if you were asked what is the cardinal sign of men1, is men1 cardinal sign of men1 is parathyroid adenoma of multicentricity is the cardinal sign of men1. Then if you were asked what is the most common manifestation of men1, most common manifestation of men1 is hyperparathyroidism. Then if you were asked what is the first investigation or abnormality seen in men1, first abnormality which is seen in hypercalcemia is seen. So these are important points about thyroid. Then we have pancreas. So in the pancreas, if you were asked, this is the second most common abnormality in men1 for after parathyroid hyperplasia, parathyroid adenoma. Then if you were asked what is the most common enteropath pancreatic neuroendocrine tumor in men1, it is actually non-functioning pancreatic polypeptide secreting tumor, which is PPOMA. This is pancreatic polypeptide secreting tumor. If you were asked what is the most common functioning one, if it is non-functioning, it is pancreatic polypeptide secreting tumor. Whereas if it is functioning, neuropancreatic endocrine tumor in men1 is actually gastrinoma followed by insulinoma. Then if you were asked what is the most common increased hormone in men1, most common increased hormone is pancreatic polypeptide is increased, followed by gastrin is increased, followed by insulin is increased in the patient. Then if you were asked some important points about pituitary adenoma, what is the most common pituitary adenoma that is associated with men1? It is prolactinoma followed by somatotropinoma is involved, followed by corticotropinoma is involved. Then if you see men2, In men 2, it is also called as men 2A or simple. This is also called as Sippel syndrome. Men 2A or also called as Sippel syndrome. This is actually autosomal dominant, characterized by medullary carcinoma of thyroid, pheochromocytoma, and also it is also characterized by parathyroid adenomas and Hertzsprung disease, and it is also characterized by cutaneous lichen amyloidosis. So what is it characterized by? Medullary carcinoma of thyroid, pheochromocytoma, parathyroid adenoma, Hertzsprung disease, and cutaneous lichen amyloidosis. Now, this is mainly occurs due to the mutation in RET oncogene, which is located on chromosome 10, and the codon which is this RET oncogene is coding is cysteine codon is coded by RET oncogene. Then we have something called as men 3 or also called as men 2B. In men 3 or men 2B, it is actually an autosomal dominant condition which is characterized by medullary carcinoma of thyroid with pheochromocytoma and mucosal neuromas will be seen, and the patient will also have megacolon will be seen with marfanoid habitus, and also intestinal ganglioneuromas are seen. This occurs mainly due to the RET oncogene mutation or chromosome 10, and here there is a mutated codon in this which is called as tyrosine kinase codon is mutated. Okay, so in men 3 or men 2B, it is an autosomal dominant condition characterized by medullary carcinoma of thyroid, pheochromocytoma, mucosal neuromas, megacolon, marfanoid futures, and intestinal ganglioneuroma. Here, RET oncogene is mutated on chromosome 10, which is tyrosine kinase codon. Now, for this men 2B or men 3, you should do prophylactic thyroidectomy is recommended. So, because of the medullary carcinoma of thyroid, prophylactic thyroidectomy is recommended. If it is men 2A syndrome, we do it before 5 years of age. We should do prophylactic thyroidectomy. If it is men 2B syndrome, it is done before 1 year of age. You do prophylactic thyroidectomy. Next, the next important syndrome is we have men 4 or also called as men X syndrome. It is men 4 or men X syndrome. This is actually men 1 associated tumors. This is a men 1 associated tumors with CDNK1B mutation. It has CDNK1B mutation, that is cyclin dependent kinase inhibitor B mutation, which is seen on chromosome 12. Here in men 4, you will see presence of hyperparathyroidism will be seen with pancreatic. Neuroendocrine tumors are seen with thyroid tumor, which is a target tumor. Adrenal tumors will be seen, and also renal tumors and gonadal tumors are seen. That is, you see thyroid tumors, adrenal tumors, and renal tumors and gonadal tumors are seen in men 4 syndrome or men 3B syndrome. Next. The next important is we have disorders of parathyroid. In the first is primary hyperparathyroidism. In primary hyperparathyroidism, it is caused by increased parathormone secretion mainly from an abnormal parathyroid gland will produce increased parathormone secretion. It is most commonly seen in females. The most common cause is it is actually solitary adenoma is most common cause, especially in 80% of cases. Most common location is it is inferior parathyroid gland. It is located most commonly in inferior parathyroid gland. This increased parathormone will result in hypercalcemia, and this hypercalcemia, the mechanism of action that leads to increased hypercalcemia is increased parathyroid increases the GI absorption of calcium. Because of increased GI absorption of calcium, it will increase calcium, and it will also decrease the renal calcium clearance and increase the vitamin D production, which will again increase the calcium in the blood by causing increased calcium absorption. So all these will increase the calcium levels in the blood. So if you see the etiology, okay, etiology of etiology of hyperparathyroidism include number 1, there will be familial predisposition will be seen, and there will be low therapeutic exposure to low therapeutic ionizing radiation or declining renal function with age, or alternation of sensitivity of parathormone to suppression by calcium and lithium therapy. Okay, all these are the etiological factors, and most cases of primary hyperparathyroidism are associated with sporadic cases. They are sporadic cases. The main etiology is familial predisposition, exposure to low therapeutic ionizing radiation, declining renal function with age, alteration in sensitivity of parathyroid gland to suppression by calcium and lithium therapy. This is actually associated with MEN1. It is associated with MEN1, MEN2A, and also it is associated with isolated familial hyperparathyroidism, and also it is associated with familial hyperparathyroidism with jaw tumor syndrome. Then if you see the clinical features are the patient will have kidney stones are seen with painful bones, and you will see abdominal groans are seen, abdominal pain with constipation will be seen, and the psychic moans will be seen in the patient. You will see psychic moans are seen within the patients, and you will see fatigue overtones. And the main symptom is the patient will have weakness, polydipsia, polyuria, then is nocturia, bone pain and bone joint pain will be there, constipation will be there, and here there will be decrease in appetite, heartburns and pruritus will be seen. And on kidney you will see the stones which are made up of calcium phosphate stones or calcium oxalate stones are seen in patients with hyperparathyroidism. In patients with hyperparathyroidism, you will see presence of osteitis, something called as Osteitis Fibrosis cystica. This Osteitis Fibrosis cystica is an advanced finding in primary hyperparathyroidism, where you will see presence of periosteal resorption of the bones will be seen. Subperiosteal resorption of the bones will be seen, with the bone cyst will be seen, and there is tufting of the bone cyst will be there with tufting of the distal pharynges. And if you see the diagnosis, in the diagnosis you will see increased concentration of parathormone, which causes increased immunoreactive parathormone. Immunoreactive parathormone will increase in patients with asymptomatic hypocalcemia. In patients with asymptomatic hypocalcemia, the parathormone will increase, and increase in immunoreactive parathormone will increase, decreased phosphate will be there, and increased 24-hour urinary calcium will also increase in these patients. And most widely used accurate investigation is technetium labeled SESTA-MABI scan is done. In these patients, technetium labeled SESTA-MABI scan is done. And then if you see the treatment, in the treatment first we have selective estrogen receptor modulator, or we also call them as bisphosphonates. These selective estrogen receptor modulators or bisphosphonates, these will decrease the calcium level, and these will also increase the bone mineral density. They will decrease the calcium levels and bone mineral density. And you can also do parathyroidectomy can be done if the patient has classical pentad. Or if the patient has age is less than 50 years, then you should do parathyroidectomy is done. Now what about the steps of hyperparathyroidectomy? First you should correct the hypercalcemia, should be corrected by giving IV normal saline should be given to the patient, followed by forced diuresis should be done. IV normal saline is given to the patient, followed by forced diuresis with the help of furosemide is done. Then we can do neck exploration also. In the neck exploration, first we will do exploration. If there is single adenoma is there, then we will resect them. If there is two adenomas are there, then also you can do resect them. And if there is hyperplasia of all the glands, that is hyperplasia of all four glands is present, then you will remove 3.5 glands are removed, whereas the remaining half gland is present is placed in the brachioradialis of non-dominant hand. It is placed in the brachioradialis of non-dominant hand. Next, if there is accidental removal of parathyroid during thyroidectomy, then you will implant it in sternocleidomastoid. Then the next important is secondary hyperparathyroidism. In secondary hyperparathyroidism, it is most commonly associated with chronic renal failure and may occur in hypocalcemia secondary to inadequate or decreased or inadequate vitamin D or calcium intake. So because of decreased vitamin D and calcium intake, there is decreased calcium. So this decreased calcium will activate the parathormone to produce increased parathormone. Okay. So here this occurs, the resultant thing is there is increased parathormone will occur, and this is because of low calcium intake or low calcium absorption. Here the signs of hypocalcemia will be there, like perioral tingling and numbness, and also there will be chest ox sign will be positive with tetany will be seen in some patients. Then if you see the treatment in this patients, you will have to advise low phosphate diet is advised to the patient, and you give phosphate binders are given to the patient, and there is adequate, and you will advise the patient to take adequate intake of calcium and magnesium, calcium and vitamin D. And you can do parathyroidectomy is done even if the parathyroid gland remains, parathormone increases even in case, or even after doing all these cases, even still if parathormone is increased, then you can do parathyroidectomy. Then we have tertiary hyperparathyroidism. So in tertiary hyperparathyroidism, then this is mainly due to the autonomous parathyroid gland functioning because of long-standing secondary hyperparathyroidism. If secondary hyperparathyroidism is present for longer period of time, then there will be autonomous parathormone functioning occurs. So because of this autonomous parathormone functioning, the clinical features like pathological fractures will occur, leading to the bone pain to the patient with renal stones will be seen, and there will be constipation will be seen in the patients, and also you will see presence of peptic ulcers are seen in the patient. So how are you going to treat this? Treat is you can do subtotal parathyroidectomy can be done, or you can do total parathyroidectomy with auto implantation of one parathyroid gland into the brachioradialis of the patient's hand. Then we have parathyroid carcinoma. Parathyroid carcinoma is responsible for 1% of primary hyperparathyroidism in the patient. If you see the clinical features here, there is symptoms will be very severe symptoms, that is the serum calcium levels will be very high, that is more than 14 milligram per deciliter will be there. Increased parathormone will be there, almost 4 times normal increase in parathormone will be there, and you will see palpable parathyroid gland is palpable in these patients. Now, if you see the route of spread, in the route of spread, the most common route of spread is local invasion is seen in these patients, and also lymph node metastasis is also seen in around 50% of cases, and you can also see distant metastasis in around 33% of cases. Then if you see the treatment in these patients, you will have to do bilateral neck exploration is done, and also you will have to do en bloc resection. You will have to do bilateral neck exploration with en bloc resection of the tumor of tumor is done, along with the you should also remove the ipsilateral thyroid lobe is removed, and also you should do modified radical neck dissection is done if lymph nodes are positive. You should do bilateral neck exploration with en bloc resection of the tumor, and also ipsilateral thyroid lobe should be removed with modified radical neck dissection should be done. Then if there is local recurrence or if there is any metastatic disease, in these cases we should do reoperation should be done. Especially it is done in cases with hypercalcemia even after the surgery of hyperparathyroidism. Then we can also give cinacalcet. Why is cinacalcet given? This cinacalcet will actually control the hypercalcemia in patients with refractory parathyroid adenoma. The thing is, this cinacalcet will decrease the parathormone by acting on calcium sensing receptors of the parathormone. It inhibits the calcium sensing receptors of parathormone and thus decreases the parathormone synthesis. Then this is about parathyroid gland. Then we have to see about adrenal gland. In the adrenal gland, one most important thing is we have adrenal incidentalomas. In adrenal incidentalomas, these are actually incidentally detected. These are incidentally detected masses which are seen, and these are actually unrelated disease. So these are mostly non-functioning adenoma. In almost 82% of incidentalomas are non-functioning adenomas. Then these also include preclinical Cushing syndrome will also be seen in almost 5%. In 5%, and you see pheochromocytoma is seen in 5%, and adrenocortical carcinoma is seen in 5%. Metastatic carcinoma is seen in 2%, and also aldosterone producing adenoma is seen in almost 1%. Then how are you going to diagnose it? Diagnosis is workup for adrenalectomy should be done. First you will have to evaluate, the hormone evaluation should be done, and also size of the tumor and history of previous malignancy is also seen. Size of the tumor and history of previous malignancy, and hypertension is seen. This hypertension is the most common manifestation of pheochromocytoma. Then you will see the symptoms of glucocorticoids, and also symptoms of sex corticoids should also be found out. Then once you have seen the history, you should do CT guided FNAC. This CT guided FNAC is actually rarely performed. Why? Because if CT guided FNAC, if performed to pheochromocytoma, this will release the catecholamines leading to abrupt increase in BP. So as a result, it is contraindicated in pheochromocytoma. So you will have to rule out the pheochromocytoma before doing CT guided FNAC. Even also in malignancy, even in metastatic disease and malignancy also, the FNAC CT guided FNAC is contraindicated, because you might cause metastasis due to your incision. Then how are you going to treat it? Treatment is, if you will have to do surgery. If it is hormonally active tumor and it is producing the symptoms, then you should do surgery. Then surgery is also done in masses which have significant risk of carrying malignancy. If the mass has risk of malignancy, even then you should do surgery. Then if you see the incidentalomas can be removed by laparoscopy. But this laparoscopy is avoided if you suspect malignancy. If you do not suspect malignancy, then you can do it by this. Then if you see the main management, if the size is more than 5 centimeters, you can do surgical removal can be done. If the size is 3 to 5 centimeters, then you strongly consider the patient for surgery. If the size is less than 3 centimeters, then you can do follow-up can be done with CT every 6 months. You can do follow-up with CT every 6 months. Next, what is the indications of surgery in a patient with incidentalomas? If you have suspicious lesion that it can be malignant, suspicion of malignancy, then in young patients you should do surgery. And if there is few surgical risk factors in the patient, then surgery. Then if there is interval growth is seen, in the tumor growth is seen, then you should do surgery. If patient wants to do surgery, patient has preference for surgery, then surgery can be done. Then we have adenocortical. The next topic in adrenal glands is we have adenocortical tumors. What are adenocortical carcinomas? First, adenocortical carcinoma is a rare tumor in which more than 50% are functional, and this adenocortical carcinomas will mainly lead to Cushing's syndrome, and also it can lead to virilization also. Most commonly it will lead to Cushing's syndrome. Then if you see the clinical features of adrenal carcinoma, it is seen in 4th to 5th decade of life, and the size of the tumor is almost 9 to 12 centimeters at the time of presentation. Investigation of choice is you will do CECT, and single most important criteria in malignancy in this adenocortical tumor is the size of the tumor is most important. Then once you have done the CECT and you have found out the size, then treatment should be done. Treatment can be done by radical open surgery is done, where you will do en bloc removal of the organ you will en bloc remove the tumor, and also you will have to remove the adjacent organs which are involved in metastasis. And you can do, if there are any regional lymph nodes which are positive, then you should do regional lymphadenectomy should be done in these patients. Okay, then if there is steroid hypersecretion in these patients, you should give drugs should be given to control the steroid hypersecretion. These drugs are, we can give ketoconazole, inhibits the steroids. Then miteripone can be given, and you can also give aminoglutathamide can be given to the patient to control the steroid synthesis. Then we have mitotane. Actually, the drug mitotane is used as an adjuvant for surgery. It is used as adjuvant for surgery. If you were asked what is the important predictor of survival in these patients, is adequacy of resection. If you resect it properly, then that is the most important predictor for survival, and it is also the most important prognostic factor is adequacy of resection. Then we have next important disease here is pheochromocytoma. So in pheochromocytoma, it mainly arises from the chromaffin cells of the adrenal medulla, and it arises in 4th to 5th decade of life. It is most commonly seen in males and females, and here if there is extra adrenal, if the pheochromocytoma is present in other areas, then we call it as paraganglioma. And the most common paraganglioma or extra-adrenal pheochromocytoma is seen in Zucker-Candle, and it is called as 10, and this is also called as 10% tumor. Why it is 10% malignant? It is 10% bilateral, 10% seen in pediatric population, 10% it is familial, and also 10% it is extra-adrenal. So we call it as 10% tumor. Then if you see the risk factors of pheochromocytoma, it can be either sporadic or familial, it can be either syndromic or not syndromic. If it is syndromic, it is associated with MEN2A and MEN2B, and it is associated with von Hippel-Lindau disease, von Recklinghausen disease, also called as neurofibromatosis 1. It is also associated with Sturge-Weber syndrome also. If it is non-syndromic, then it is associated with succinyl dehydrogenase deficiency. Succinyl dehydrogenase A and B mutation also it is associated with. Now if you see the pathology, in the pathology it is mostly unilateral and solitary, except 10% is bilateral, 10% malignant. So here if you see this pheochromocytoma, you will see this in multiple endocrine neoplasia also, but it is rarely malignant. Almost only 10% of the cases you will see malignancy. Then if there is succinyl dehydrogenase B and D mutation, succinyl dehydrogenase B and D mutation, this has increased propensity to extra-adrenal, and it can also cause malignant pheochromocytoma can occur if the tumor is by succinyl dehydrogenase B and D mutation. Then if you see the normal pheochromocytoma, it will produce both noradrenaline and adrenaline, but the production of noradrenaline is more than that of adrenaline. But if you see the extra-adrenal pheochromocytoma, this will produce noradrenaline, and exclusively it produces noradrenaline because of the deficiency of phenylethanolamine N-methyltransferase, which will help in conversion of norepinephrine to epinephrine. This is deficient, and as a result the extra-adrenal pheochromocytoma will not produce adrenaline, it produces only norepinephrine or noradrenaline. Then if the pheochromocytoma which is associated with MEN1, this will produce adrenaline only. Then if you see the malignant pheochromocytoma, this will produce dopamine, homovanillic acid, and also the criteria of malignancy. When do you say that pheochromocytoma is malignant? This is mainly based on the metastasis only. Vascular invasion and capsular invasion is seen in both malignant and benign tumors also it is seen. Then you have clinical features. Here the patient presents with headache, diaphoresis and palpitations will be there. And the patient, this headache is the most common symptom of the patient, and most common manifestation of the patient is hypertension is the most common manifestation of the patient. If you were asked most common symptom of the patient is headache. Then if you see the pathophysiology, in pathophysiology there will be increased heart rate, increased total peripheral resistance, increased blood pressure will occur, and in pheochromocytoma there will be volume depletion. Because of volume depletion there will be decreased blood pressure, decreased blood volume. There will be decreased blood volume will occur, decreased plasma volume will occur. Then what about the clinical features? Here there is sympathetic overactivity is seen because of epinephrine and norepinephrine, which will result in weight loss in the patients, and there will be carbohydrate intolerance is seen in this patient. So if you see the cardiac manifestations, you will see presence of sinus tachycardia with supraventricular arrhythmias are seen in the patient, and also you will see ventricular premature contractions are seen. So if you see the investigations, important, most sensitive is screening test. The screening test is you have to do vanillyl mandelic acid levels or catecholamine levels can be measured in urine. Then if you see what is the best test for diagnosis is you can diagnose it by fractioned plasma metanephrine levels. Then if you were asked what is the investigation of choice for adrenal pheochromocytoma or extraadrenal pheochromocytoma or in pheochromocytoma in pregnancy, in all these cases MRI is the investigation of choice. Then we have MIBG scan. It is used for extraadrenal pheochromocytoma. MIBG scan is used for extraadrenal pheochromocytoma. Then we have FNAC and biopsy. This is actually contraindicated because if you do FNAC and biopsy, it can lead to hypertension crisis in the patient. So we contraindicate it. Now if you see the treatment of the patient, treatment is we give preoperatively, we give non-alpha blockers are given to the patient. These non-alpha blockers will actually control the blood pressure. The drug of choice of non-selective alpha blockers. Preoperatively, we give non-selective alpha blockers which will control the blood pressure. The drug of choice is we can give phenoxybenzamine can be given to the patient. And then if you see, we can also add beta blockers are given if tachycardia appears in the patient, and beta blockers are only given until the patient is fully alpha blocked. That means first you will give alpha blocker and then you will give beta blocker. If you give the other way around, like beta blocker followed by alpha blocker, once you give beta blocker, the patient will start suffering from orthostatic hypotension. So to prevent this, you will give first alpha blocker followed by beta blocker. Then if you were asked what is the treatment of choice, is adrenalectomy is the treatment of choice in these patients. Then laparoscopic adrenalectomy can also be performed if the tumor size is less than 5 centimeters. Then what about the malignant pheochromocytoma? In malignant pheochromocytoma, mainly the risk of malignancy will increases with age, with size. Risk of malignancy will increases with size. Here these malignant pheochromocytoma will express P53, BCL2, and they also have activated telomerase activity. Then what is the most common site of metastasis? Most common site of metastasis is actually bone followed by lymph node is the most common site of metastasis. This mainly secretes dopamine and homovanillic acid are produced by malignant pheochromocytoma. The treatment of malignant pheochromocytoma is you have to do resection followed by chemotherapy is given to the patient. Then if you see the next important thing, what agents are used for chemotherapy? In chemotherapy you can use either vincristine can be used, cyclophosphamide can be used, and you can use gracarbazine can be used in the patient. Then next important disease which is here is neuroblastoma. This neuroblastoma will arise from the neural crest cell and it can originate anywhere along the sympathetic chain. It can originate anywhere along the sympathetic chain. Then the next important thing is what is the most common site of neuroblastoma? It is mostly seen in adrenal, followed by it can be seen around the vertebrae, paravertebral, followed by it can be seen in the retroperitoneal region also, followed by it can be seen in posterior mediastinal region or pelvic region or cervical area. Next, this neuroblastoma is the most common tumor which is diagnosed in infants who are less than 1 year of age. It is the most common intra-abdominal malignancy which is seen in children is also neuroblastoma. Then the unique feature of neuroblastoma is it undergoes spontaneous regression. Now the question is, what are the different cancers which can undergo spontaneous regression? Spontaneous regression can be undergone by most of the childhood tumors like neuroblastoma, choriocarcinoma, retinoblastoma, malignant melanoma, and renal cell carcinoma. Neuroblastoma, choriocarcinoma, retinoblastoma, malignant melanoma, and renal cell carcinoma can undergo spontaneous regression. So if you see the clinical features, it is most commonly you will see presence of a fixed mass. Lobular mass is seen which extends downwards from the midline, extending from the flank towards the midline of the abdomen like this. It is mainly seen in the age of 2 years of age and it is seen before 4 years of age. Almost 60 to 70% of patients are diagnosed at the time of metastasis only. So in the metastasis, the baby will develop orbital metastasis, which are called as, where the patient will develop periorbital ecchymosis is developed along with proptosis, which is called as raccoon's eye. This is called as raccoon's eyes. And in infants with 4S stage will also develop cutaneous metastasis, and these are called as blueberry muffin rash. So blueberry muffin lesions are also seen in these patients. Then if you see the usual metastasis, usual paraneoplastic lesions, like they can be present with chronic watery diarrhea will be there, and opsoclonus, myoclonus will be seen in the patients also. That is dancing eyes and dancing feet. If you see what is the most common metastasis site is, it is mainly in the long bones you will see main metastasis, and also in the skull mainly the sphenoid bone is involved in the skull. For the metastasis in the skull, sphenoid bone is involved, and long bones are the most common site of metastasis. Then here in infants, the metastasis is confined to the liver, or it can be confined to subcutaneous tissues also. And if you see, the lung metastasis is actually rare in neuroblastoma. Then if you see the next lab findings, in the lab you will see that the patient will have anemia, he will have thrombocytopenia with increased LDH will be there, with increased ferritin you will see, and there will be increased urinary catecholamines will be seen, and increased neuron specific enolase is seen in the patient. On X-ray you will see presence of stippled calcification is seen in the patient. Along with that, if you do IVP on intravenous pyelography, you will see presence of drooping lily sign will be seen on intravenous pyelography. And you can also do MRI followed by CT can also be done, especially for vascular invasion and patency and spinal cord compression. Then if you see the treatment, if there is localized neuroblastoma, then you can directly excise the tissue. But if it is unresectable neuroblastoma, then in unresectable neuroblastoma you should do biopsy of the lesion, and then you should do downstage the lesion by giving the chemotherapy can be given, and radiotherapy can be given, followed by you can do surgical resection in the patient. Then we have something called as Aesthesia Neuroblastoma. So if you see in Aesthesia Neuroblastoma, in this we have, it is a rare tumor which is seen in neural crest or in origin. It is seen in neural crest origin. It arises from the basal cells of olfactory mucosa, especially of cribriform plate, and also it arises from the upper nasal. Upper nasal wall also. So, and also superior turbinate also it arises. Okay, so if you see the clinical features, there will be in the nose nasal cavity you will see presence of a polypoidal lesion will be seen in the nasal cavity, and this polypoidal lesion will cause nasal obstruction, and it also causes anosmia and epistaxis in the patient. Now how are you going to treat it? You will have to do simple surgical excision should be done in the patient, followed by you can give radiotherapy to the patient. Thank you, and thank you for watching.